My name's Will Irving. It's my pleasure to welcome you to the third in the series of webinars on COVID-19 being organised by the Royal College of Pathologists. And it's a real pleasure to invite my colleague, Dr Louise Berry, who's a consultant in infectious diseases and virology here in Nottingham. And Louise very kindly agreed to talk to us about the clinical presentation of COVID and its initial management.
Thanks very much, Will, for that introduction, and welcome to everyone who's joined in for this evening's short seminar. So I've been given the fairly monumental task of trying to cover clinical presentation and management of COVID in a very short time of 15 to 20 minutes. So the areas that I'm going to try and cover are the spectrum of COVID disease that we're seeing, and also the spectrum of severity as it manifests in many different ways, and sometimes atypically. I'll share a couple of cases that we've seen recently in hospital, just to illustrate this, and talk a little bit about pathogenesis, including risk factors for severe disease and management. I am aware that future speakers are going to be talking about treatment trials, so I won't spend too much time on that. So my first slide is an illustration of the spectrum of disease. So what we see is a wide range of symptoms, from very little or no symptoms to mild disease to severe disease with respiratory failure and multi-organ failure requiring admission to critical care for organ support. The mortality rate of the most severe cases is around 50% in the UK. And the percentages that you're seeing here are based on the largest published cohort of patients from China, where they looked at over 56,000 patients. From that data set, their case fatality ratio was initially reported as about 3.6%, but a reanalysis of those figures, adjusting for the milder cases that we're seeing, including infections in younger persons, shows it's more likely to be 1.38%. And actually, this may still be an overestimate, as the true number of asymptomatic cases and very mild cases aren't completely known. Again, this data that we see is from the China cohort and shows the most frequent recorded symptoms of those presenting to healthcare. So typical symptoms include fever, dry cough, fatigue, shortness of breath. But there are other atypical symptoms such as diarrhea, conjunctival congestion. Initially, the high frequency of fever and cough were used as key diagnostic criteria to prompt suspicion and testing for COVID. But as we go on, we are learning that the manifestations are wide and varied, and sometimes quite subtle. So we risk missing diagnoses if we just look for typical symptoms. The first case I'd like to present is of a 57-year-old man who was brought in by ambulance on the 6th of April. He had a history of 12 days of shortness of breath and cold and flu-like symptoms. And interestingly, at the same time, he lost sense of taste and smell. And he came in because he was developing worsening shortness of breath with oxygenation at 70% with the ambulance crew. Now, the average time to presentation to hospital from onset of symptoms is around 7 days, and he had several comorbidities that put him at increased risk of severe disease, including hypertension, diabetes and asthma, and also being male put him in a higher risk category. When he was examined, he was speaking with minimal discomfort, and it's quite a common finding that patients on initial presentation aren't overly or don't appear overly distressed and can sit up, have a full conversation despite these quite profoundly low oxygenation levels. Another key finding or clue in this case was his low lymphocyte count at 0.6% and the renal dysfunction. And in fact, this patient got intubated and ventilated that evening, and to this day remains on critical care. You can see here from his initial chest X-ray that he has some mild patchy changes in the medial lower zone of the right lung, but they're quite subtle actually. And in fact, chest X-ray can be normal or non-specific in 40% of cases. And performing a CT on the same day can actually reveal much more extensive changes than initially apparent on the chest X-ray. This CT scan that we see on the right shows quite extensive pulmonary consolidative changes with air bronchograms involving the majority of both lobes. And you can see the upper lobe ground glass opacities noted. This CT scan was taken about 10 days after his initial chest X-ray. In terms of the spectrum of severity, we're learning more about the pattern of disease at different time points in the illness. So classically, patients start to develop symptoms on about 5 days after their infection and present with malaise, fever, dry cough, as the virus targets the respiratory epithelium initially. For many, this will be the only manifestation of disease and the recovery is uneventful. However, some patients develop more pronounced lung involvement with shortness of breath, hypoxia, and infiltrates on lung imaging around day 10 when they develop a viral pneumonia, which is in this second stage. Of this group, some will progress to stage 3, which is characterized by a hyperinflammatory state associated with a surge in pro-inflammatory cytokines such as IL-6, leading to respiratory failure, shock, multi-organ failure, and thromboembolic events. When we think about the pathogenesis, we're learning more and more about this as we go along, and how it explains some of the clinical manifestations we're seeing. So we know that the viral spike protein uses the cellular ACE2 receptors to latch onto and gain entry to the cells in which it replicates. These ACE2 receptors are found in numerous cell types, not only within the respiratory tract, but also in gut, kidney, heart, and neural tissue, which may explain some of the extrapulmonary features we are seeing, for example, diarrhea, anosmia. When the virus reaches the alveoli, the replicating virus causes cellular damage, which attracts further recruitment of immune cells such as macrophages. And pro-inflammatory cytokines are produced, which in turn cause endothelial leakage. This leakage results in the accumulation of fluid within the alveoli and impairs the gas exchange. Over time, this leads to fibrin deposition and clot formation within the small vessels in the lung, which can then extend to larger vessels in the lung. And in fact, raised D-dimers and PEs have been a common finding in critically ill patients. It's also postulated that ACE2 has a downstream effect on increasing bradykinin levels, which may also explain why patients in ITU are often difficult to extubate due to their edematous airways, a little bit reminiscent of angioedema. So this explains some of the classical COVID CT findings, such as ground glass opacification, reticular pattern, which is known as crazy paving, and the peripheral consolidation that we see on the CT scans. However, we have to bear in mind that ground glass opacification can be seen in other disease processes, and we mustn't forget about alternative treatable diagnoses such as PCP pneumonia, which can mimic COVID. We must also remember that although this is a classical CT, there are various, this as well is a spectrum. So it's not always obvious that it is COVID. and in fact some CTs have been reported as heart failure or fluid overload. So who gets severe disease? So a number of risk factors have been identified. We can see on the right-hand side that death rate varies by age, health and sex. So the older you are, the more likely you are to get the severe disease and die. We're seeing very little COVID illness within the pediatric population. And this might be due to the expression of this ACE2, which is less in children. We also know that males are much higher risk, and this may be due to the effect of androgens on ACE2 expression. We also see that viral loads are higher in the older population, but viral loads aren't statistically different in those with mild versus severe disease. We've also seen that comorbidities such as hypertension, diabetes, COPD and malignancy give rise to higher rates of severe disease. But there's also a complex interplay between genetics, viral factors and immune factors. And interestingly, in the original SARS, a faster antibody response was associated with a poorer outcome. In these patients, their antibody response was not sustained and was not effective at neutralizing the virus. So paradoxically, an early IgG antibody response stimulated pulmonary pro-inflammatory responses and caused acute lung injury. What are the observations from ICU? Well, talking to my colleagues in critical care, they tell me it's not like anything we've seen before. It was initially described as ARDS, but it's really not a classical ARDS because the lungs are much more compliant than we normally see in this acute respiratory distress syndrome. And the profound hypoxia that we're seeing may be more due to a mismatch between ventilation and perfusion. These patients often have long stays on critical care, requiring ventilatory support. And as I've mentioned, they have quite a common complication of thromboembolic events like DVTs, PEs, and ischemic strokes, with pulmonary emboli being seen in up to 40% of ITU patients. As of last Friday, 8,752 patients have been admitted to intensive care units in England, Wales and Northern Ireland with COVID. And of those which we have outcomes for, the mortality rate is 50%. If we compare this to non-COVID viral pneumonias such as influenza, that mortality rate is 22%. And we are seeing that almost a quarter of these patients will need renal support, renal replacement therapy, and advanced cardiovascular support. So this is not a one-organ disease process. In terms of risk factors for death, this includes the severity, the extent of the lung involvement, multi-organ failure, and disseminated intravascular coagulation and low lymphocytes, and has also been associated with elevated cytokine markers such as IL-6. So for example, DIC or disseminated intravascular coagulation has been found in 71% of those who died, as opposed to less than 1% in survivors of ITU. And in terms of co-infections, we've not seen much in the way of co-infections locally, other than what you would normally expect for patients on intensive care, such as ventilator-associated pneumonias and line infections. So, as I've alluded to, this is just not a single organ disease, and we're starting to see more and more manifestations outside of the lungs. So some of these extrapulmonary manifestations will be direct virus invasion and disruption of the tissues, whereas some, like encephalopathy and ischemic stroke, may be the result of cytokine disturbance and a prothrombotic state. Interestingly, in a series of autopsy samples from China, they saw that there was direct parenchymal infection of tubular epithelial cells and podocytes seen on electron microscopy with marked tubular injury, which goes some way to explaining the level of acute kidney injury that we're seeing. In the elderly, like with other respiratory infections such as influenza, we often see atypical presentations. So quite commonly, elderly patients will come in with falls, confusion, or decompensation of comorbidities such as heart failure, abdominal pain. So these can be in the absence of the cardinal classic signs such as shortness of breath, cough, and fever, making it really difficult to differentiate between who has COVID and who doesn't. The implications of this are that COVID can go unrecognized and the necessary infection control measures aren't taken, leading to nosocomial transmission within the hospital. This is an MRI scan of acute hemorrhagic necrotizing encephalopathy. On the left-hand side, you will see this, these lesions within the temporal lobes bilaterally. And on the second image, the hypointense areas are areas of hemorrhage within the brain. My second case is, well, I'm calling it atypical COVID, but more and more this is a kind of typical presentation in the elderly. So this is a 95-year-old gentleman who had a background of schizoaffective disorder and myocardial infarction, but no real underlying cognitive impairment as such. He was found confused by his landlady and in the emergency department was drowsy, disoriented, and resisting care. But you can see here that he actually didn't have a fever, he had normal respiration rate, and he wasn't requiring oxygen with quite a good oxygenation level. However, on his bloods, he did have an elevated CRP and lymphopenia, but his chest x-ray was initially clear. However, after 3 days, he deteriorated, requiring oxygen, more and more short of breath. And this chest x-ray was repeated, which is what you're seeing here on the right-hand side, which has some of the classical COVID features of peripheral ground glass opacifications. Sadly, the patient died on the 5th day of his admission, and post-mortem testing found him to be positive for SARS-CoV. Now, when he was admitted, it was early on in the pandemic, and the diagnostic criteria essentially were shortness of breath, fever, cough, and essentially he didn't tick any of those boxes, so it was not suspected in this patient. I think we're getting a lot better at recognizing some of these atypical presentations, and we've got a low threshold for suspecting COVID disease. But diagnostically, decisions can be complex, and underdiagnosis is as problematic as overdiagnosis. And we are potentially at risk of missing other treatable conditions such as atypical pneumonias. So we've got to keep an open mind when it comes to this diagnosis. So I'm going to talk a little bit about asymptomatic and mild disease. It's difficult to quantify the true number of asymptomatic infections, but some recent studies, seroprevalence studies, offer some clues. Unfortunately, none of these studies have been published yet, so we don't know the exact methodology that they use, but it's interesting. It gives you a flavor of the level of background infection. So in Miami, they found that 6% of those that they tested were positive, but interestingly, only 50% of them had symptoms in the preceding 2 weeks. So when they extrapolated from that data, the number of infections was potentially 17 times the number of those captured through PCR testing sites and local hospitals alone. This is a paper that's really interesting. It was published just last Friday in the New England Journal of Medicine. And it was a point prevalence study of a Washington state nursing home where initially several residents had tested positive. And what they did was test residents 1 week apart on 2 occasions. And overall, about 2/3 of residents tested positive, but only 56% of these 56% of these residents were asymptomatic at the time, although saying that most did develop symptoms on average 4 days later, with fever in 71% and cough in 54%. But we can see from this chart that they had PCR positivity several days before the onset of symptoms, and they had a positive viral culture. So this raises the possibility of transmissibility of infectious virus in these pre-symptomatic patients. So let's move on to management. In the absence...
Louise, it's Will here. Do you think you could round up in a couple of minutes? I've already got a pile of questions to ask you.
Oh, yes, I'm on my last 3 slides.
Lovely.
Sorry if I've gone over time.
No, that's fine.
So in the absence of a vaccine or proven treatments, supportive care with organ support and prevention of secondary complications such as thromboembolism and ventilator and line-associated infections are key. We need to be able to develop good palliative care to those both in and out of hospitals. And for those patients not fulfilling criteria for hospital admission, we need close monitoring when at home of those patients, particularly for those in the high-risk groups, which may require readmission. Infection control measures are critical to reducing transmission of the virus to other patients within the hospital and upon discharge. And I'd like to talk a little bit about therapeutic targets that could be used. So these are the key pillars of infection control that can help reduce spread, including testing of patients and symptomatic staff. And from those results, and in addition to the clinical suspicion of COVID, we need to design pathways in order to accommodate and cohort patients who have COVID, who have suspected COVID clinically, and those who are unlikely or not COVID. This requires good clinical acumen and early recognition of the typical and atypical presentations. And we need to be able to have the facilities to isolate and cohort patients and provide patient distancing. But in many hospitals, these facilities are lacking. And the other pillar is PPE, personal protective equipment, and it's not just the accessibility to this, but the correct usage to prevent spread from staff to each other and to other patients. Hand washing is critical, and environmental measures such as decluttering and meticulous cleaning of ward areas will also reduce transmission within the hospital. In terms of therapeutics, we can think of these in 2 broad groups, those that target the virus and those that target the overexuberant inflammatory response. To date, we only have RCT data for lopinavir, ritonavir, which is a repurposed HIV drug. And the authors found no benefit over supportive care. However, we have to bear in mind that that was a very specific patient group, recruited relatively late in their disease, and they were receiving various other interventions. What we really need is well-designed and well-powered RCTs to help us answer these important questions about efficacy. And also timing of these interventions is crucial, as immunomodulatory drugs given early on may hamper the ability to clear the virus, and antivirals given too late may be of little benefit. So final thoughts, there are many unanswered questions that are not only fascinating but are important for us to answer so we can gain the upper hand and control of the virus. So firstly, what extent does transmission occur in those with little or no symptoms and in the pre-symptomatic phase? And what are the key drivers pushing some patients down the path to severe illness and death? And what therapeutic interventions work best for who and when? We also need to collect data on specific patient groups, such as transplant patients and pregnant women, to understand their vulnerabilities better. And looking to the future, we need to know how long following infection do we have a protective immune response? And importantly, how can we best plan for the upcoming winter when we have the added pressure of other respiratory viruses in the mix? So thank you very much for listening. Sorry if I've overrun. I've tried my best to try and bring this down to 20 minutes. Thank you for your patience. And thank you to my colleagues in the Infectious Disease Department and Microbiology Department, particularly the lab team. We've done an amazing job at getting PCR rolled out in record speed, and the infection control team who are doing an amazing job in the hospital. Thank you.
Thanks very much, Louise. Could you release the screen?
Yes, so stop share.
Yeah. So thank you to everybody. I've been reading your questions as they're coming in, and I'll try and group them together in related areas. So at least there is some good news that many patients recover from this infection. Do you have any feel for long-term effects, particularly fatigue or long-term lung damage, or is it too soon? Have you not seen these patients coming back to outpatients yet?
No, but we can certainly draw from the Chinese data, because they're ahead of us in the game. They've got data now going back to about 4 or 5 months. So in terms of the more severe cases, we're seeing lung fibrosis, scarring of the lung in those severe cases, where there's been a lot of inflammatory damage to the lungs. So they may be left with some long-term residual lung damage. In terms of the milder cases, I mean, we see with a lot of other viral infections such as EBV and CMV that it can result in a chronic fatigue syndrome. So whether that is the case with COVID as well, I think we've yet to see how the long-term complications manifest themselves. Okay, so during the acute presentation, I've had a few questions asking about how can we identify early on patients who are going to end up needing intensive care. And clearly that's a very critical question, especially if patients are in a more remote area and may or may not need to be transported to where they can get intensive care. So I could ask the general question, are there any markers? But I've also had a number of possibilities sent to me. So does measuring IL-6 help in that, or LBP? I have to confess that's a new one on me, lipopolysaccharide binding protein. Lymphopenia. Are there any other promising biomarkers that can be used early on? Yeah, so people have looked at LDH and lymphocyte counts and found an association with those developing severe disease and poor outcomes. There was a recent meta-analysis by Wynantz et al., which failed to draw kind of conclusive findings in terms of predictors of mortality and severity in terms of admissions to hospital and those going on to develop severe disease. It was dyspnea, essentially feeling short of breath, which kind of seems obvious. But I think looking at all the different studies, a lot of them are open to bias. So I think those offers called for a kind of more clear, consistent way of reporting those markers to really help us predict who was going to require critical care support. I think some places have also used artificial intelligence models, and I'm sure something very fancy will come out where we can plug in all the information and essentially come up with a percentage risk of requiring critical care. Okay. What I would say is that some people who initially present to hospital with milder symptoms may be sent home, and the higher risk groups such as elder males, those with comorbidities that put them at increased risk, really need a good eye kept on them with kind of daily follow-up to make sure they're not falling into that severe disease category, because they can decompensate very quickly and require critical care support.
Okay. From a point of view of pathogenesis, I'm interested, maybe it's an unfair question, but why is lymphopenia such a pronounced sign? Because most virus infections induce lymphocytosis.
Yeah, so they find that the CD3 and CD4 counts can be low in these patients, and I think, I'm not completely sure, but I think it's because the virus infects these lymphocyte subsets and causes a reduction in the levels.
I've had a couple of questions about ACE as a receptor and ACE inhibitors in patients who have hypertension. So one was, should patients on ACE inhibitors continue to take them? And is there any evidence that continuing to take those inhibitors produces particularly more severe gastrointestinal infection? I'm not quite sure why it should be gastrointestinal. But...
So I think we still have lack of clarity on this issue because a lot of it's drawing from extrapolations or theoretical possibilities that ACE inhibitors could increase the expression of ACE2 on cells. Others would argue that actually they may even have a beneficial effect, and so the recommendations currently is to keep taking what you normally take. It's anecdotal evidence, but talking to critical care colleagues, they see a lot of patients with hypertension, both on ACE inhibitors and off inhibitors. They didn't feel like there was a strong association there, but I'd be interested to see what the Intensive Care National Audit and Research Centre does, because I think once you plug this data into a multivariate analysis, it may be that other factors are more strongly associated with severe outcomes. So more data to follow on this one to draw really conclusive findings.
Okay. If we look at the two extremes, I've got questions about the elderly who are presenting with, not really presenting with typical symptoms. Is there any evidence that nasal swabs or throat swabs are more likely to be false negative in those individuals? They don't have respiratory symptoms?
I don't think so. I don't believe that they would be more likely to be falsely negative. Actually, some studies show that they have higher viral loads in the older groups. So I don't think there should be an issue with inability to detect it. I think there's a lot of other variables, such as how well you take the swab, that might be contributing to that.
Okay, and related to that, your second case came to a post-mortem.
Yeah.
was asked, at what stage was this diagnosed? Was infection suspected before he died? And if
No,
not,
it wasn't. So this gentleman presented fairly early on in when we were starting to see cases. At that time, the diagnostic criteria we had to hand was fever, shortness of breath, and cough. And he didn't actually present with any of those things. He just presented confused. But actually, this is something that we're seeing quite commonly on the healthcare of the elderly wards, that the presentation can be a lot more subtle, and we really have to have our wits about us and have a low threshold for testing. Because sometimes it can just be diarrhea, being off legs, yeah.
okay.
A little bit like what we see in influenza. So whereas in a young person would be myalgic, have shortness of breath, have a sore throat and fever, in the elderly, they may present to the hospital with flu as confusion, being muddled, and decompensation of their heart failure, for example. So,
Okay, and at the other end, children, there've been one or two reports of an inflammatory-like illness, like Hepatitis disease.
Yeah, it's interesting that this has come up very recently. And interestingly, just today I had a call from a consultant on pediatric intensive care unit where they had 3 patients where they were suspecting this Kawasaki-like illness, but they said it was like nothing they'd really seen before. It didn't quite fit into a kind of typical Kawasaki, but patients had myocarditis. One child had a bowel perforation, very shocked. And one of those patients did actually test positive for COVID, but the other 2, despite lots of different sample types, nothing came up positive on the PCR results. So whether this is actually a kind of post-infectious or para-infectious manifestation, presenting as a type of vasculitis, it's difficult to know. We've essentially, we're at a stage where this is just people on conference calls comparing notes about these odd cases. So we've got a lot to learn on those. And this is where serology might be useful. And just to see whether there is evidence of recent infection with COVID.
Okay. Extrapulmonary manifestations, CNS, has anyone reported finding the virus either in CSF or post-mortem brain?
Yeah, well, most of these cases of, for example, encephalitis, the CSF is actually negative. But in one case they did find the virus there. But I wonder whether, if, for example, we had a brain biopsy and PCR'd that, we would find the virus. It's a little bit like the kidneys, where we very, very rarely see it in the urine. But obviously, when they went in and looked under an electron microscope, they found the virus. So perhaps it's the compartment that we're actually testing.
Okay. And I think I've got through almost all of them, but there's a couple recently that are related. So testing for other respiratory viral pathogens and co-infections. So are there any particular organisms that are emerging as likely co-partners, as it were?
Not really seen much in the way of co-infection, but we have seen quite a few kind of misdiagnoses where on one hand, we are encouraging people to think COVID, don't miss COVID. But at the same hand, we don't want people to miss other treatable infections. And there's been a case recently of a patient coming in with respiratory distress and ground glass opacification, and everybody thinks, COVID, but it was actually a presentation with PCP pneumonia in a newly diagnosed HIV. So there are things that we mustn't forget to send off the samples for the other respiratory viruses, mycoplasma, things that can present atypically
Okay.
and are treatable.
I did say it was going to be the last one, but there's another comment here which is interesting. What about home monitoring with pulse oximetry?
Yeah, I think that's a really good idea. So there's been different models being used, and some centres use a model of like a virtual clinic. So if the patient comes in COVID positive but has very mild symptoms, and they could go home, they don't require admission to hospital at that time point. If they're in one of these higher risk groups, so if they're older, they're male, they have comorbidities, the sensible thing would be to safety net them, have regular follow-up, and that could be a telephone follow-up or a Zoom follow-up. But if they had the ability to monitor their own oximetry, that would provide reassurance that they weren't deteriorating, because they could present when they start getting mild symptoms, but obviously we know that it's 7 days down the line when they actually run into trouble and need to come in for oxygen support. But perhaps oxygen therapy at home might be another solution. Okay,
well, thank you so much. We've covered a huge range of ground, and you have survived my interrogation, so well done for that.
Oh.
There are one or two questions I didn't get a chance to ask, but I think we covered almost everything. Thank you again to Louise, and
thank you.
Good night to everybody.